So I am Marilyn Ritchie. I'm the Vice Dean for Artificial Intelligence and Computing in the Perelman School of Medicine here at the University of Pennsylvania. I also am the Vice President for Research Informatics in the University of Pennsylvania Health System. I'm delighted today to be joined by my co-host, Dr. Renee Vidal. Would you like to introduce yourself?
Yes, I am Renee. I'm a professor in radiology in the School of Medicine, as well as in electrical and systems engineering in the School of Engineering at Penn. I'm also the director of the Center for Innovation in Data Engineering and Science, which is a joint initiative between arts and sciences and engineering for AI and data science. Thank you, Marilyn.
Thank you. Well, thank you all for joining today. We are joined by 5 faculty members from the University of Pennsylvania who are leaders in the world of AI and healthcare. Today, we're going to talk about how artificial intelligence is transforming every corner of healthcare, from dental exams to home care, medical imaging to gerontology and beyond. Our panelists will dive into the real-world impact of AI in their respective fields, the challenges of implementing AI responsibly in clinical settings, and the bold opportunities ahead, such as the possibility of a foundation model for medicine. We've also allocated some time later in the hour for audience questions. Feel free to raise those questions in the Q&A function of the webinar. You can also feel free to upvote one another's questions, and we'll try to get to the questions at the end that have the most votes. So as we start, I would like to introduce each of our panelists. So first, we have Marcus Blatz from the Penn Dental Medicine. Dr. Blatz is a professor of restorative dentistry, the chairman of the Department of Preventive and Restorative Sciences, the Assistant Dean for Digital Innovation and Professional Development, and the Associate Director for AI and Digital Dentistry at the Penn Dental Medicine Center for Innovation and Precision Dentistry. Professor Blatz is also the founder of the Penn Dental Medicine CAD/CAM Ceramic Center, an interdisciplinary venture that studies emerging technologies and new ceramic materials while providing state-of-the-art aesthetic clinical care. Second, we have Dr. Patricia Flatley Brennan, the Provost's Distinguished Visiting Faculty Fellow for the 2024-25 academic year. Before coming to Penn, Professor Brennan served as the Director of the National Library of Medicine at the NIH and the Lillian Molhem Bascom Professor at the School of Nursing and College of Engineering and Chair of the Department of Industrial Engineering at the University of Wisconsin-Madison. I'd also like to introduce Dr. George Damiris, the Mary Alice Bennett and Penn Integrates Knowledge PIK Professor in the School of Nursing and the Perelman School of Medicine, and Associate Dean for Research and Innovation in the School of Nursing. Next, I would like to introduce Dr. Allison Pouch. She is Assistant Professor of Radiology at the Perelman School of Medicine and Bioengineering at the School of Engineering and Applied Sciences, respectively. And finally, we have Dr. Gary Weissman. He is Assistant Professor of Pulmonary and Critical Care Medicine at the Perelman School of Medicine and a Senior Fellow at the Leonard Davis Institute of Health Economics. Renee, I will pass it to you.
All right, thank you, Marilyn. Let's begin by hearing from each of you about the most exciting developments in AI you're seeing in your domain, whether it's a breakthrough tool or a new workflow or a big idea. What's something that signals you that AI is changing the game in your part of the care spectrum? Let me begin with Marcus.
Thank you so much. Well, it's a little bit difficult to just pinpoint one specific area because the great thing about AI right now, as it is with all our lives, has an impact on all the aspects in our work. And of course, the whole academic spectrum from teaching to conduct customized learning programs to the research where we can, of course, be much more precise with the research that we're conducting and also with the analysis of that. In our field, you may not know, but dentistry, of course, is a very clinical area. And in that area, AI actually has for many years already had a big impact. When we fabricate restorations for our patients, there's of course a certain treatment planning involved. There is a fabrication process. You mentioned CAD/CAM earlier. That's computer-assisted design, computer-assisted manufacturing, has been part of our workflow for many, many years. However, what we can do now with AI, and this I think where in our clinical work is the most important. We can really customize the treatment to each patient. Of course, we try to do that anyways, but one of the advantages of using these tools that we can do is much, much faster. For example, it starts with diagnostics. As you all know, using diagnostic tools that can read radiographs to help us with better treatment planning, disease prediction, and in our specific area now, we can use radiographs, scans of the mouth, of the face, to really come up with customized crowns, bridges, or dentures. And using all the aesthetic parameters and the functional parameters to make a restoration for you that's specifically fitting your needs, desires, aesthetics, and function. And this is an area where, again, AI has, I think, in the last couple of years, the biggest impact in this treatment planning. When you use orthodontics to move teeth in the right direction, when we're making the restorations on top of that, we can make this customized to every patient. This is, I think, one of the biggest thing, because in the end of the day, for us, the most important thing to provide the best possible care for our patients. And these tools really help doing that. And as an addition, we can provide better access to care. That's why my vision would be also to use these tools to provide more efficient, effective, cost-effective care for our patients, specifically in areas where they may not have the quality of care that they probably deserve.
Thank you, Marcus. That's really exciting. Patricia, tell me about what excites you most about how AI is transforming your field. If you could please unmute.
AI is transforming nurses' abilities to see into the future. As a nurse and an industrial engineer, I am constantly focused on the systems that we use to deliver care. Nursing is the diagnosis and treatment of human response to development, disease, and disability. Nurses engage with patients over the course of their lives and over the processes of care. Therefore, nurses attend to processes of living and processes of healing. I keep focusing on this idea of processing because it is a much different strategy to build models for than a point estimator, for example, like a diagnostic. Work done by Kendrick Cato here at CHOP and Penn and at Sarah Rossetti at Columbia show that AI models that can integrate the subtle but critical aspects of care, such as the number of times a nurse walks into a room or the number of different people in a room, provide nurses with a prediction of how that individual is doing, an extra set of eyes that can serve as an early warning system, alerting a nurse to a change in a patient's status, maybe a risk of a sudden decline. Additionally, ambient dictation systems and other AI tools can assist nurses by making documentation more efficient. However, these systems must be complemented by developing a new set of skills among nurses and other practitioners to create new cognitive processes that help them better and more creatively evaluate notes that are generated by an AI system versus composing the note themselves. They are challenged to assure that these notes are accurate, timely, and they meaningfully communicate both the patient's status and the care events to others in the care team, as well as to future uses of those records, for example, for AI or billing. So fundamentally, the education and training of all nurses is undergoing a revision to move our critical thinking from compositional to critical analysis.
Thank you, Patricia. Same question for you, George. What excites you more about how AI is transforming your field?
Thank you. My field is in gerontology and specifically looking at ways to support older adults and their families. And what excites me most is AI's potential to fundamentally shift how we understand and support aging. Not just by predicting risk or automating tasks, but also by enabling personalized, more comprehensive and proactive care for older adults and their families. And this can be from tools that detect early cognitive decline, using behavioral signals to voice assistants that alleviate loneliness, home-based solutions that prevent falls, and many more. We see more and more tools where AI opens doors to interventions that are tailored, personalized, and human-centered. I'm part of an initiative called Penn AI Tech, which is the Penn Artificial Intelligence and Technology Collaboratory for Healthy Aging. And that's funded by the National Institute on Aging. In that initiative, we fund several pilots each year that look at AI to advance aging, as well as those living with dementia and their family members. And here we see a lot of innovations across settings, AI tools that are consumer-facing to be used in the home, in long-term care facilities, in assisted living facilities, but we also see biology of aging applications. And one thing that all those different projects have in common is that they demonstrate that AI, when designed appropriately, can become not just a tool for care, but actually a catalyst for autonomy, connection, and purpose across the lifespan. And I'm especially excited about the potential for AI to introduce new models of care in the gerontology space.
Thank you, George. Allison, what excites you most about AI advancing your field, radiology?
So I'm in the field of medical imaging research, specifically medical image analysis, automated medical image analysis. And something that I'm really excited about is how we can use AI to help medical providers develop new skills and also increase patient access to medical imaging technology. So what I mean by that is that we can use AI to help medical providers acquire high quality diagnostic images in settings where that can be sometimes difficult. So to give an example, my research group is really excited to participate in an ARPA-H program called Paradigm, which is developing vehicles to deliver hospital-level care to rural communities where there aren't brick-and-mortar hospital facilities. And one of the challenges of working in such an environment is that it's understaffed. So there aren't going to be medical providers who have specialized training in providing all of the procedures and diagnostics that that patient population needs. So we're part of an intelligent task guidance group, which is developing AI tools to help walk medical providers through medical procedures like ultrasound imaging. So imaging with ultrasound is very user dependent. It can be tricky to get high quality images, especially for providers who don't do it on a regular basis. So what AI can do is provide real-time feedback about how to optimize the ultrasound, how to move the ultrasound transducer to improve the quality of the image, how to update the settings to get really nice diagnostic views. So for example, you could diagnose a patient who might have critically poor cardiac function. So what I'm describing here is the process of upskilling, where AI is helping providers developing new skills while taking advantage of the training and the experience that they already have. The reason why this excites me a lot is that there's a lot of discussion and concern about AI replacing jobs, but I think the opposite can also be true. It can also introduce new opportunities for providers and also increase healthcare access for patients. And the example I gave is just one of many in our radiology department of researchers doing the same, increasing access to this imaging technology.
Thank you, Allison. And last but not least, Gary, what excites you most about how AI is transforming your field?
Thanks, Renee. So glad to be here with everyone today. So I'm a pulmonary critical care doc, and I work mostly in the medical intensive care unit. And I'm most excited about AI because the availability of that technology has given us a new choice that we haven't had to make before. And that's for a given task that we do during our day, we are now faced with the option to say, should this task be done by an AI or should it be done by a human, or maybe some combination of the two? And on the one hand, an AI system is very likely to do things much faster, much more efficient than a human can. On the other hand, there are some tasks where we really do want a human involved. And I'll give you an example. When I'm in the ICU, we're getting lots of data sources, lots of data all the time. And if someone sends a fax over to the hospital, which, believe it or not, still happens in this day and age, And AI, I think, is very well suited to read the contents of that fax and put it into the electronic health record. As long as it does it accurately, I don't think we're missing out too much on having a human in the loop for that kind of a task. On the other hand, there's been a big push towards having AI systems do note summarization or chart summarization, which on the one hand, I'm certain an AI can do a lot faster than I can. On the other hand, I don't know yet, and I don't think anybody knows yet, both how we should measure the accuracy of that kind of task or what we lose out as a human being reading through the chart and thinking, because that process of reading, thinking, reflecting is really a part of the clinical decision-making process and the practice of medicine. So what I'm excited about really is that AI is forcing us to think about this and reflect on this and really identify how we can make the practice of medicine more cost-effective and efficient, but also while really focusing on what are those human parts of medicine. And my hope is that we can do that with a rigorous scientific framework, with wisdom, with attention to the costs and potential harms of doing that. And I think if we do that well, everybody can benefit.
Thank you very much, Gary. Back to Marilyn.
All right. Well, as we move from kind of AI hype to implementation, which from what we're hearing today, we're doing some implementation, a lot of concerns arise. Things around bias of the algorithms, trust, workflow, access, regulation. I'm curious, and some of you have alluded to this, but maybe you can unpack it a little bit more, what a specific challenge is in your domain that we need to address head on to ensure that AI is not only innovative, but also safe and responsible and equitable. So I think we'll use the same order. So Marcus, I'll start with you. What's a challenge
Okay.
that you see in being responsible in integrating AI?
Well, again, we have talked about the good and the bad, and it goes, unfortunately, almost hand in hand. When we look in, I mentioned before, customization of care, of course, is a big topic for us. But yeah, if the information that is being used to customize that is not correct, we have a problem. That's why we always have to, as Gary mentioned very, very nicely, we always have to take our factor into that and when we make those clinical decisions. And because the danger, as you said, is that how good is the data that AI makes the decisions on? And where get we into this process? And that's why I'm not afraid that we're going to lose our jobs, because we will still always have to have that role to identify if the information is correct or not, and using additional clinical knowledge and tools to verify that. In our field, when I look at the entire academic spectrum, I think one of the most dangerous areas is, of course, the research part, where I see that just using some of these, research writing tools and understanding the information that you're getting, it could be totally wrong based on the data that is being fed into the system. And I think this is where we talk a lot about evidence-based dentistry and how important it is, but tools that allow us to also make a qualitative assessment of the research that's being used to make those decisions are extremely important. And at this point in time, it's still very fragile, and unfortunately, when you use some of these, writing tools, there's some references that are completely made up, or it pulls from all the references that are available without a qualitative assessment. And I think that's really dangerous, because this is what we have to make our clinical decisions based on. And if those tools are not sound, that's I think is a big challenge for us and for our patients, of course.
Yeah, great point. Patty.
Thanks very much. And I appreciated Marcus's attention to both the clinical and the researcher use of AI. And I'm going to focus a little bit more on the clinical and policy level uses of AI. I see calls for ethical AI or demands for the assurances of equity enhancing AI solutions. But I encourage you to think that this necessitates us moving our attention about ethics and equity upstream into the design, development, and deployment process, and also in the data generation process. It's way too late to simply try to bolt ethical considerations on the end of an AI solution that has already been developed. We need to look at what assumptions went into the development of the base models, of the clinical application model, and of the data generation, and ensure that those assumptions are consistent with the values that we have for care. Now, this is a lot to put on the clinician at the end of the rope. And so we have to be careful we don't overload our clinicians and say, make sure you understand the system before you do this. I believe much can be learned through partnerships with humanities, social sciences, and philosophy. These disciplines have a language and a grammar that incorporates perspective, human experience, and social values into assessment and formalization. And there is a strong and active cadre at Penn in the areas that can be helpful, not simply to bring AI into the arts, but bring the arts into AI. Another strategy I would encourage is to rethink the process of model building and model deployment. I've been an engineer for over 40 years. We love to build things fast, break things quickly, but point of fact, prizing precision, fast solutions, and other delivery strategies over a reflective process is actually not as effective in creating an AI system that actually reflects the ethical and complex social values within which those systems are going to be used. To resolve this challenge of responsibly, ethically integrating AI into healthcare, we need to focus on the building, the data generation, and the selection activities of what data will be used for both training as well as applications, and the specific model implementation. Who is at the end and what is actually happening as that model is being delivered to that individuals. We need not to have every clinician build their own AI systems and not to have every engineer sit next to a clinician for careers, but we need to help our clinician colleagues become adept at creating the tools, to knowing when to best deploy them, to knowing how to understand the data sets that are being used. This will require us building a chain of trust, which we have already done in team-based care, but needs to be expanded to include our technical colleagues. Thank you.
Thank you. Great answer. George, what is a challenge that you see in responsibly integrating AI into your area?
Yes, actually, the challenges really relate to the points that Marcus and Patty both made. I think more specifically in gerontology, one major challenge I see is to ensure that AI systems do not perpetuate or amplify ageism. We've talked a lot about bias in AI, and we've seen many studies document racial or gender bias. And I think there can also be ageism as a potential source of bias, whether it's through biased data, exclusionary design, or assumptions that devalue the capacities and diversity of older adults. There's also been many clinical trials and other initiatives and interventions that have excluded older adults from their design. So in a way, many of these AI systems use data sets that have at baseline already excluded older adults as part of the training data sets. I think another major challenge is in terms of how we can responsibly integrate AI into gerontological systems, is to ensure interoperability and integration into complex care ecosystems. Older adults often interact with a wide range of services, medical, but also social, home-based, long-term care, rehabilitation, and many more. And oftentimes AI tools are developed in isolation from those interconnected systems. So without seamless data sharing or aligned goals and cross-sector collaboration, even the most sophisticated AI tools as a standalone tool can fall short in real-world settings where we deal with older adults with complex care needs experiencing multiple care transitions. And at the same time, many instances require a dyadic approach where we treat the end user as the older adult patient and their families, and creating systems that take that into consideration and invite older adults to be part of the design process. As Patty was saying, having those considerations much more upstream, not after the tool has been designed, but early on when we can actually capture the voice and the true needs of the end users.
Great, thank you. Allison, your turn. What is a challenge that you see in responsibly incorporating AI into your area?
I think my feelings on this will echo some of the great points already made, but one of the greatest challenges I see, especially related to medical imaging, is really the generalizability and validation of AI tools. So much of our research focuses on developing automated algorithms for interpreting anatomy and images or making diagnoses based on medical images. And what's very common is that you might train an algorithm and it works very well at one institution, but then when it's deployed at another institution, the performance is not as strong. Or we might make use of a tool that's been undergone a validation study, has been published, and when we start using it under different circumstances, again, the performance starts declining. And for medical imaging specifically, there's so many factors that inject variability into medical imaging that make generalizability a challenge. For example, we have so many different commercial imaging systems. We have different image acquisition protocols. And in the case of ultrasound imaging, that can be very user dependent. There are various image reconstruction algorithms that give MRI and CT data different spatial resolution, different image appearance. So all of these factors mean that we really need large, diverse data sets in order to make these algorithms generalizable. And as some of the other panelists highlighted, then you also have the patient population underlining this data. Wherever the model is trained, there's going to be some bias associated with respect to the patient population. So the other factor is validation. I don't think validation really occurs once and that's it. Anytime we inject new data into a model, it's going to change its performance. And if that's done dynamically, you could have some performance drift in these algorithms. So there really needs to be really careful surveillance and version control of these AI tools. So we're really understanding what we're applying and what data that model was trained with. So overall, I think there have been a lot of efforts to help mitigate these challenges. There's a lot of research in data harmonization, community efforts to build a large benchmark data sets for testing, and also just encouraging researchers to do multi-institutional development and testing. But overall, I think transparency in the model development process and the data that was used and understanding any types of assumptions we're making when using AI tools, those things are all really critical to address these challenges.
Yeah, great points, Allison. The model drift one is a worry that keeps me up at night. I worry a lot about models drifting, and then if we don't revalidate and care changes, we're actually applying care to old information, and that would be terrible. So it's something I think and worry a lot about. All right, again, last but not least, Gary, what do you see as a major challenge in responsibly integrating AI into your area?
Thanks, Marilyn. I fully agree with all the great comments from the co-panelists here. And I'll say that I think the biggest challenge is that we lack epistemologic consensus about how we really know things about AI systems. And what I mean by that is most of us are at least vaguely familiar with probably how drug development works. So for example, if there's a new compound that kills cancer cells in a petri dish, we might say, okay, that's promising for a new cancer treatment, but that doesn't mean we're about to start giving that compound to everybody with cancer who walks through the door. We need to do safety testing, we need to do clinical trials, that we need to know a lot more about that compound before we can start using it. But AI is much newer. And so I don't think there's good consensus or understanding about how we really know things about AI. And the biggest misunderstanding, at least in critical care, is the huge gap between a model's predictive performance in silico and how that model might actually affect care decisions and certainly patient outcomes when that model is deployed in clinico, if you will. So I think really understanding that gap is key. And it's really important because even if a model, an AI system, could predict a diagnosis or a treatment perfectly, if it's not delivered in the right way or at the right time or to the right person, it's not actually going to help anybody at the bedside. Conversely, if you have a model that doesn't get the right answer much of the time, but maybe you give it in such a way or at the right time that it causes a clinician to pause and deliberate, and maybe they don't even listen to the AI, but because of that prompt, they deliberated for a few more minutes and came up with a better decision. That model with worse performance in silico could still actually improve patient care more. And so the gap between that in vitro petri dish like development of AI models and their performance is so far away from the bedside. And I think we need to develop a better collective understanding of how we get from one to the other, and to do that with rigor and, like you were saying, Marilyn, with really rigorous evaluations of safety, effectiveness, and equity.
Yeah. Thank you. Thank you all for those great answers. And as I pass it to Renee, just a reminder to the audience, feel free to put your questions for this panel into the Q&A feature in the webinar. All right, back to you, Renee.
Thank you, Marilyn. So I've been working on AI for about 25 years. And in thinking about the last 10 or so that we've seen this great revolution in AI for images and AI for text, I think of a couple of potential ingredients. One of them was naturally the availability of data, both text and images, that has been to some extent enabled by all of us posting our images on websites and obviously all of the text that is available in the internet. Second, the ability to have computational infrastructure to both label these data as well as to compute with GPUs. And third, the emergence of these deep learning and now foundational models that are incredibly large and now trained on maybe multiple different tasks, and therefore they can solve many tasks all at once. And I guess the example that all of us are familiar with is large language models, that we are just astonished of the ability of these models to respond any questions we might have. So moving forward and looking ahead, what do we need in order to make these successes effective in healthcare and medicine? Do we need new infrastructure? Do we need better data? Typically in medicine, data is protected and not necessarily shared across all hospitals, so it's not put in the internet for everybody to use. Do we need better regulation for sharing that data, or are we going to be building foundational models that say can solve all medical imaging problems at once rather than focusing on a very specific question? So let me begin with Marcus in dentistry. What do you think are going to be the areas where AI is going to be truly transformative, and how is that going to happen?
In dentistry, I mean, you just mentioned all the key points actually that are important. And what the problem is right now for us and using these tools from the clinical side is, of course, that there are different silos of data, there's different silos of programs that are available, and they don't speak with each other. Of course, data has to be better. There has to be some regulation on we talked about ethics before as well. But the key is then, if we have good tools available, how can we start having them talk to each other? And when I look from the clinical side, from the dental side, as I mentioned, it starts with the treatment planning. Having tools available that will allow us to be more precise with our treatment planning, but also taking into consideration the individual clinician, as Gary has mentioned as well, is a key point. It's not, especially in dentistry, where everything is pretty much handmade, so to say. And coming from this treatment planning to being able to produce with the different silos that we have now available, restorations that are fitting our patients in the best possible way. And so the main transformation, I think, will occur once we're able to bring these tools from the analysis of our radiographs, CBCTs, the intraoral scans, the knowledge of the dentist, bring it all together based on the specific needs of each patient, and then being able to transfer also, of course, their dental concerns into something that's healthier. But the problem is right now, I think, is that we have these different silos, and right now I don't see any tool that would bring this together to really help us I mean, more efficiently, more effectively. But that would be my dream, to having a platform that will, bring all these aspects together.
Great. Pat, do you want to go next?
Sure. So Marcus has a vision of enormous integration, and that is a far reach. But I think I'm going to propose something that's an even farther reach. In order to make AI truly transformative in medicine and healthcare, we need to increase the alignment between data generators, model builders, and users of AI systems. And most importantly, we need to increase the alignment among the clinical disciplines and within the delivery systems. We have a broad structure of perverse incentives that in and of themselves can undermine and place enormous strain on AI models that may actually conform to one ethical principle or another, but may not conform to the entire system's ethical principles. So in order to ask for AI to be helpful in medicine, we actually have to start with medicine, with alignment, with understanding about the various roles and contributions from different disciplines and how to make those accessible and of value, and then build models on top of that. This is where I believe the foundational models actually need to take a step or two out from the focus on solving a solution to solving a problem in context, including the variety of perspectives on this. From the methods development side, there is a need for new kinds of methods to accommodate both the quantitative as well as the contextual, conceptual, messy, semantic information about patient status into some kind of predictive or analytic methods. Some of the work going on at Penn by Meyer Nayek's group is actually quite exciting to me about this, where he's attempting to build a new language that actually aligns what we would consider semantic as well as quantitative information into single models. This will do more than providing a solution based on one or the other, but rather leads us towards integrated solutions. Secondly, I call on my technical colleagues to begin to realize there's more than one right answer. So AI solutions that lead to a single point of action are useful, but not enough. And Marcus actually illustrated, or sorry, Gary illustrated a good situation where a less highly performing model can actually improve the clinical situation because it stimulates thinking. Finally, I would like us to better understand the range of uncertainties around solutions. It's okay that there is uncertainty. We have to bring our clinician colleagues along to be able to understand what that uncertainty is. Now, in turn, clinicians have to continue to develop skills in conveying relevant aspects of these very complex clinical situations so that the problem shapes the solution, not that the solution strategy confines the problem. Thank you.
Wonderful. Do you want to go next, George?
Sure. I think just to add to what my colleagues have said, I think to make AI truly transformative in medicine, we need more than just technological innovation. And we've been talking about the need for trust, transparency, and alignment with clinical needs and processes. And that means rigorous validation of algorithms across different and diverse populations, seamless integration into the clinical workflow, meaningful collaboration between engineers, computer scientists, clinicians, and patients and families and other stakeholders, but also requires thinking or rethinking incentives, prioritizing outcomes that matter to patients over efficiency alone, and figuring out the ideal parameters to ensure that AI augments rather than replaces human relationships. I think we also need robust policy frameworks that would ensure safety, equity, accountability. This includes standards for algorithmic transparency, pathways for regulatory approval that match the pace of innovation. I feel with AI, sometimes things happen so fast from the technology perspective that the clinical, the ethical, and the policy considerations are always as an afterthought trying to catch up. And we need policies that mandate representative data and continuous post-deployment monitoring. We also need to think about reimbursement models and how they should evolve to support AI tools that improve outcomes and not just productivity metrics. Ultimately, without aligned policy, even the most promising innovations within AI run the risk to remain siloed or unevenly deployed, or not really gaining the trust of the clinicians and the patients. So as with any innovation, I think we need to make sure that the technological advancements go hand in hand with policy and clinical utility considerations.
Thank you, George. Those are really excellent points. So same question for you, Alison, but maybe with a little twist. I think in your field is maybe the one that is the closest to AI for computer vision and natural language processing, in that there is already available data sets, say for chest X-rays. There is already reports from radiology that are available. There are already people working on automatic report generation. So do you see the future as all of those tools being really integrated in the clinic, and maybe no more radiologists, or radiologists maybe being able to see and produce reports much more easily by having all of those tools available?
I think there is a lot of headway being made in report generation. But and you're definitely, I totally agree that there are a lot of openly available imaging data sets. But I would argue it's not there. There's not enough. Okay, we do have troves of X-ray images and ultrasound, but they still don't even come close in scale to what we have in computer vision, like pictures of cats and dogs in buildings that are used in the broader field of image-based AI. So that being said, I think hospital systems are sitting on huge troves of this image data that hasn't been leveraged for AI tools. And I think what we really need to get us there is improvements in infrastructure. On the projects that we do in my lab, where we're doing computational image analysis, one of our biggest challenges is, or something that takes up a lot of time in our projects, is de-identifying the images, organizing them with consistent image formats, making sure they have the right study IDs associated with them, and things of that nature. That data cleaning really takes up a lot of effort. And something that I've been seeing that I'm really excited about is efforts like the Penn Medicine Biobank. My colleagues put a lot of effort into bringing multimodal data together, whether it's imaging, genomics, text reports, office visit notes, or whatever it is. I really think that those efforts are going to be transformational in getting us access to those images so that we can develop high quality AI tools. And I do hope moving forward that, as you said, there are a lot of X-ray data sets out there, know the number of MRI ones as well, but ultrasound really, there's not enough openly available shared benchmark data sets there. So I think if we can develop and share those high quality data sets, that could really, really have a big impact in medical imaging and diagnostics.
Thank you so much, Alison. Gary, same question. What would it take to make AI truly transformative in medicine, in your view?
Thanks, Renee. It's really hard to go last on this panel to think of something good to say after all those comments, but I'll see what I can do. I totally agree with all of the co-panelists, and I think mostly what I'm saying is underscoring or repeating what has already been said, but I'll say it now in a slightly different way, and hopefully that provides some food for thought, which is, I think we need a stronger, tailored ecosystem for AI. And what I mean by that is, it's not just about the technological innovation, it's also that we need, like George was saying, much stronger regulation at the federal level to ensure safety, accountability, and effectiveness. We need a payment system that's sustainable. Like Patty was saying, for clinicians, we need to make sure that they're involved in the right way to make sure AI systems are supporting their decisions at the bedside. And that includes, in the same way that we have a very robust infrastructure for laboratory tests, we need a similar local oversight mechanism similar to CLIA to make sure that when an AI model is trained in Chicago or Palo Alto, that when we bring it here to Penn, that it's still going to perform as well and do what we expect it to do. And I think in the short term, that stronger ecosystem will provide the guardrails for innovation, ensure safety and accountability. But if we can get that ecosystem into place, it will also set us up for, I think, what you're asking, Renee, which is like, what's the golden ticket here, the golden ring? What do we really want to get to? And I think taking a step back in AI, we've seen incredible innovation from reinforcement learning tools that have been able to, these are games, chess and Go, but vastly outperform real humans with new strategies, new approaches that humans have never even considered. But we can't use those tools in medicine in the real world, because you can't just deploy a robot into the operating room or the ICU or the emergency department and say, hey, go make some mistakes, but you'll learn, you'll figure it out. That clearly we can't do that. But if we put the right guardrails and ecosystem into place to deploy reinforcement learning algorithms in real learning health systems in a way that's safe, in a way where we have accountability and guardrails, then we may actually be able to benefit from those AI approaches in healthcare.
Thank you, Gary. Excellent points. I agree completely. So we already have a large number of questions from our audience. So Marilyn is going to ask our panelists some of those questions.
All right. Yeah, these questions are great. I've had a hard time choosing, but I'm going to go with one that in my vice dean for AI role, I think a lot about. I would love to hear feedback from whichever panelists would like to respond. And this is around the fact that while there is still so much work to be done, and we've been talking about that today, and so much to think about in terms of ethics and doing things right, there are already a lot of AI capabilities happening in healthcare today. There are tools that already have AI embedded and tools that are coming out every month. How do we prepare clinicians and staff for using the tools and effectively assessing the tools today? And I guess I would even add to that question, do you have thoughts on how we also prepare the next generation of healthcare provider learners? So, a lot of the kind of medical students and nursing students today, they've already been using AI and all sorts of things in high college, and now they're using it in medical and nursing school and dental school. And so they're hoping their current teachers will teach them, but we need to teach a lot of the teachers how to use these tools so that they can effectively teach that next generation. So I'd love to hear if anyone has thoughts on how do we prepare today's clinicians and staff, but also how do we think about this next generation? And whomever would like is what, Gary, if you want to go find, you're welcome, if you have thoughts.
Oh, sure. Yeah, I have lots of thoughts. And I'm curious to hear what other people think too. I think one answer to those questions is before deploying AI systems that clinicians and staff have to deal with, make sure that those clinicians and staff are involved upstream in the choice to deploy those systems. Because I think we do a disservice to our clinicians in the same way we wouldn't go deploy some medical device in an operating room or an ICU without making sure clinicians really knew what it was, how to use it safely. Even though there are incentives that our health system has to deploy these systems, I don't think that always is the best for patient care or for staff and clinician well-being. So I think getting them involved early and often and always is one step.
Great. Patty, you see your hand?
2 points. One is that I believe that clinicians learn interpersonally more than anything else. So what we need to adopt in this era is a peer learning, train the trainer, whatever framework works best in your place, so that as clinicians use a tool, they have someone next to them that they can say, this is what I did, this is what it did, what do you think? The second piece is that I believe all levels of clinician and all types of clinicians need a private space occasionally to have a conversation, to be able to say the things that they don't want to say in front of their trainees, or they don't want to say in front of their supervisor, to say, I really don't know what this does, or I really don't trust that this other person made a good decision about this, whether to deploy this system. So in addition to having peer training accountabilities, which I think we've learned recently about patient safety and bystander trainers, that peer training does actually work really well. We need to also have occasional safe spaces where peer clinicians can have free-flowing conversations unencumbered by status or possibility of censure.
Yeah, we've been through that on several occasions with other tools, especially as you mentioned, CAD/CAM technologies. The industry has really undergone a great transition in the last 10, 15 years. And many of our colleagues who are also teachers who were trained 20, 30 years ago have not been trained with those tools. So again, as was mentioned, yeah, training, making sure that we can update our colleagues and our students as well. And we're also using some tools now for our students to make a more customized educational approach, to have a customized curriculum based on their specific needs and preferences, based on their the challenges that they may face. And I think this is also where AI can be used very, very positively into the training process, but making it tailored to the specific needs or the challenges or the lack of knowledge in certain areas that our colleagues and students have. And again, we have been quite a bit through updating our colleagues over and over again, and this will be just another tool. Using as mentioned before, radiographic analyses, we have a number of different systems available now that help us. It's much more easier in dentistry because we have these small radiographs, and it's much more easier than probably what Allison has to do with 3D analyses and other tools to use these to detect carious lesions, to see if there's a crown. Many of these, I would say, big DSOs, big dental conglomerates of practices and also insurance companies already jumped on these very, very quickly to then make a quality assurance with those tools. But again, learning process, training, I think, for our colleagues is the most important thing.
Great. All right. Another question that I'm going to actually combine two questions. There was one about, and Patty, it was directed to you, but I think if I combine it with the other, others could answer part of it as well. But you made some comments earlier about looking to other fields like social science and humanities and their contributions as we think about AI in practice. Someone else also asked about patients, that patients are often the last group that we invite to kind of supply their thoughts and opinions and support around AI tools. Both questions are kind of asking how you all think about incorporating these kind of not medical, not technological, not engineering perspectives. So the social and humanities, but also patients as we start to think about incorporating AI into care. Patty, I'll start with you since the one question was really directed to you.
Sure. I think it's imperative that universities like Penn continue to have their core liberal arts content available to all undergraduates, because that is one of the ways individuals learn the languages of these other disciplines. Social science in particular offers us ways to identify, label, and resolve what appears to be differential perspectives or conflicts of interest that might actually, once surface, be able to make the AI design and utilization work much better. And finally, I find that as I've talked to individuals in humanities, they're first of all skilled at preparing students with skill sets, not necessarily for specific jobs. So they have a lot to teach us about how we create a skill set with an individual. But secondly, they're also used to using the product of their work, particularly performance and creative artists, the product of their work, they already anticipate what will the intended user be doing when he or she looks at this. And I think that whole way of thinking about the end user is a novel way that could be helpful.
Right. George?
I would add to that in terms of the second part of your question, how could we engage patients or others in the design of AI tools? I think that's a real important step, but also a very challenging one when we recognize that people come with different levels of experience, backgrounds, and so forth. So I do think it would be important to include patients in the design of AI tools early on, focusing also on how outputs are generated, not only what they say. And that does sometimes require an ongoing dialogue and potentially cultivating AI literacy for different user groups that they may not have. But just like when we conduct research and we use informed consent, we cannot say this research study is too complex for you to understand, so just sign here. We actually have the responsibility to ensure that people fully understand what's going on. Similarly, I do think as we design AI systems, we should be able to address the clinical relevance, the validity, levels of transparency, safety, and risk to patients early on and hear their say and their needs. One of the problems often when we design systems, not just without a lot of engagement, but without the end user at the table, as we know that we come up with systems that are based on assumptions that may not meet true needs. And I think that is exacerbated in AI, where sometimes we don't have the patient's voice in the design phase, and then we may not have a heterogeneous enough of a training data set, for example, for that system. So we end up kind of exacerbating that challenge.
Marcus or Allison, do you have any comments on that? I'm thinking specifically, I mean, I've certainly been in kind of, MRI situations and also dental situations where I'm told, oh, we're using AI now to analyze this image. It's more so in the practice, not in a research setting, but I'm just curious if either of you have thoughts on how you're engaging with patients on kind of the application of AI in their care, if you're hearing much from patients.
Yeah, I don't know if I have too much to add in terms of patients, but one thing I would like to share, because I'm not a physician, but work very closely with physicians, is that it's just how important it is to drive home the point that it is a partnership between the physician and AI. I think there's a lot of fear behind job replacement, and this can, I think sometimes physicians can perceive that it's a competition with AI, and I never see it that way at all. It's really meant to be a partnership. And I think that's important to emphasize, I think, in their training and as we try to introduce tools, and also have patients understand that too, that it's not, I don't think AI is taking over and managing their medical care, but again, it's a partnership with their physician.
Oh, if I just may jump in real quick. Yeah, I mean, for us, it's been huge to integrate the patient into the decision-making process, because as I mentioned, we can use AI tools to just, scan. First of all, we scan their teeth, we scan their faces, then use AI tools to make a customized setup of dentures, of crowns, whatever. The patients love that because they're getting directly involved. We can show them after a few seconds, listen, this is what we could possibly do. And nowadays, with the CAD/CAM technologies, we can also provide that. In the past, we had some of these tools as well, but we're not able to then really transfer it into that final stage. It looked great on a picture, but we couldn't do it. Now we can integrate all these tools together and say, okay, this is what it could look like. This is the type of restoration that you need. This is the type of materials that would be best in your specific situation. Patients love that. Also, those radiographic tools, we can then now, for example, show them a tooth that has a carious lesions. We can then put colors into that and have the AI tell us, okay, this is what's there, this is what's there. We can show that patient that on the screen and say, listen, this is the situation, and explaining things much, much better. So from the patient communication tools that we have with AI, it's been actually incredibly successful.
Thank you. All right, Renee, I'm going to pass it to you to share closing remarks.
Thank you, everybody. This has been absolutely exciting. I feel I've learned so much about it, and I'm sure that audience online has as well. I just wanted to say that this event, our AI in Healthcare webinar, was organized by Penn AI, which is a university-wide initiative for advancing AI and data science at Penn. This initiative really is aimed to foster collaboration across the 12 schools at the University of Pennsylvania. We began on April 1st by having a panel by the AI Council, and this is our second online event. And I just wanted to say that many more events like this for other areas of AI are upcoming, including a large symposium that will be organized on campus during the fall this semester. So I encourage others to follow up online. This webinar will be recorded and posted on the YouTube channel, and you can stay tuned also via Instagram, Facebook, LinkedIn, and YouTube. Let me take the opportunity to thank all of our panelists, Marcus, Patricia, George, Allison, and Gary. All of them took time from their very busy schedules to tell us about their recent advances of AI in their field, and we are very thankful for that. Thank you, everybody who was able to make it online. And finally, happy Juneteenth. Hope to see you next time.